Okay. How was it? You guys gained something out of that video, I hope. Excellent, excellent. Okay. So, so let's talk about the endocrinology emergency. Okay. All right. Nice. Okay, cool. Yeah, I have another video I probably will share next meeting in next week. So yeah, let's get back on track. So we'll talk about the endocrinology emergency in the emergency room. So different types of emergencies related to the endocrinology, but really the ones we're going to focus on today are the diabetic related emergencies and the thyroid related emergencies. We kind of touched these regarding the adrenal insufficiency at the beginning. So now we will focus on those two. So number one is diabetes related emergencies. So diabetic ketoacidosis and the hypersmolar hyperglycemic state, or the other name is hyperglycemic non-ketotic hyperglycemic syndrome, I believe. So that was, I think, the old name. So we compare those two, and we will gain a lot by this comparison. So as we all know, diabetes is our really biggest enemy here in Saudi. Is almost 35% of the population have diabetes, either type 1 or type 2. So that's why it's one of the chronic diseases really we need to pay more attention to and consider the preventive medicine and to have the primary, secondary prevention activated more properly, inshallah, with the movement with our healthcare system toward privatization and toward more patient-centered care. So DK, from the name of DK, diabetic ketoacidosis. So this patient should be diabetic and have high hyperglycemia, high glucose in the blood, and also should have a high ketone in the blood, which is keto, the reason for it. And the ketone is related to lipolysis. When the fat tissue is break down to generate energy, you will get the ketone in the blood. And the last thing is acidosis. The pH will change accordingly because you're using the ketone to generate energy, and the ketone will increase the pH. Sorry, will decrease the pH, so you will have acidosis. So key factors with the diabetic ketoacidosis. Usually it happens with the diabetic type 1, but honestly nowadays I see many diabetes mellitus type 2 patients comes to the emergency room. They come to the emergency room with DKA, even though they are type 2. So stress is one of the big factors. Non-compliance with medications, if they're not taking proper dose of their insulin, or they're not taking their medications properly. So they would have hyperglycemia, and a few days later, they would develop the diabetic ketoacidosis. Infection, if the patient have a severe infection, just like the COVID-19 pneumonia nowadays, most of the COVID-19 pneumonia patients will have hyperglycemia, then they might develop diabetic ketoacidosis. Also iatrogenic, if they're actually just not aware of how to take the medications. Someone used to have her son or his son give the dose, and the son is busy now, not available, then they don't know how to take the medication. They develop the DKA. So many different factors, but the big ones we just talked about. And there is another uncommon cause of diabetic ketoacidosis is myocardial infarction. So that's another one. And most of the times we actually not paying attention to because we focus on the DKA. But if you have a patient with severe like uncomfort feeling in the abdomen and the epigastric area probably, and they are at high risk of myocardial infarction, then you definitely need to check the ECG and the troponin in case you are suspecting, if you have like ECG changes that goes with ischemia. I remember a case I had about 3 years ago. The patient came from Hail, like they took the ride with the car because their father was actually around 75-year-old diabetic on insulin, and he started vomiting severely at home. Then they took him to the hospital in Hail. They gave him a subcutaneous injection of insulin, and they asked him to go to another hospital because he is too sick to be handled by that team. So they moved to a different city in the way. So they decided to come to Riyadh, but in the way to Riyadh, they had another episode of vomiting, and their father had really kind of ultimate level of consciousness. They had to stop in the way, and they give him IV fluids. So I'm just telling you the story to understand how really poor the care sometimes from the providing physician. They give him IV fluid to improve his mental status. They thought it was dehydration. And they gave him another dose of insulin subcutaneously and ask him to move forward. Patient came to the emergency room and I saw him. We did check his glucose as soon as he came in. Was really sky high, unreadable by the machine. Then I start talking to the family because he looked really sick to me. So we ordered ECG. As we know, three different people that they usually have atypical chest pain: elderly, diabetic, and female patients, those three. So he was elderly and diabetic, uncontrolled diabetic patient. And he was breathing really kind of deep, but really slowly, with some concern that he's actually having cosmal breathing. And this is expected, so deep, shallow breathe. And the other reason for me, because he was sweating. So I was concerned that he might have some stress happening. We did the ECG, and I like unfortunately found that patient to have anterior wall myocardial infarction, ST elevation involving the anterior wall leads from V1 to V4. All of those were actually with ST elevations. And I did the bedside echo for him, and that confirmed my concern. His anterior wall was not moving at all. So the heart was really suffering, and he developed diabetic ketoacidosis on top of that. So the stress was related to the myocardial infarction. Then he did not do a good job with his medication. So myocardial infarction with diabetic ketoacidosis. So we start managing him to protect the rest of the heart. We also start him on the DKA protocol, and slowly, because the troponin was sky high, and as you guys know, the troponin will start kicking in within 3 hours, 2 to 3 hours, and will continue to be high for 14 days, around 14 days. So when we found his troponin to be, I believe, 16,000 or something around that number, we realized that actually 2 days ago, when the symptoms started, the vomiting was actually due to probably the myocardial infarction. So he is 2 days after the beginning of the like the attack, which is too late to and he was unstable when he arrived. So we did not take him to the cath lab. They took him 2 or 3 days after we controlled his symptoms, and we controlled the diabetic ketoacidosis. But alhamdulillah, he survived after that. So this is really a case I'm sharing with you just to make you feel like, okay, sometimes really don't get distracted with what is given to you. Some people will take it for granted. Okay, they will say his blood sugar is high, and we are coming from high just because of this. Please give him something to control. So he will take it for granted. They said this, so this is what's happening. No, emergency room physicians should think beyond that. I should think beyond what the normal people would think about. Think about life threatening. And as we know, diabetes, one of the stressors is myocardial infarction. And another one that you should also keep in mind, especially with most of them having epigastric pain when they come to the ER, think about pancreatitis. So those are two crazy, life-threatening conditions that you should keep in mind when you have a patient with diabetic ketoacidosis present to your emergency room. So myocardial infarction and pancreatitis, other than the usual causes or stressors to cause the DKA. Okay. So they would have the ketone, so they would have lipolysis, and pH will be low. And because of the high hyperglycemia, as we probably remember, glucose, when it goes to the kidney, if the glucose level more than 180 in the blood, then the kidney cannot tolerate that and start washing out the glucose in the urine. And as the glucose goes with the urine, it will take some fluid, water. So water with the glucose goes in the urine, and that would lead to osmotic diuresis. So because of the osmolarity change with the glucose going out, it will take also some water with it, and that will lead to dehydration. Dehydration is the first to correct when you have diabetic ketoacidosis case. Okay, keep it in mind. Correct the dehydration with IV fluids, then start correcting the electrolyte disturbance and start correcting the hyperglycemia. Okay, so the pH will be low and the bicarb will be low because it's metabolic acidosis. Then you have to think about the onset. Usually it's hours to days, unlike the hyperglycemic and then hyper osmolar state. It goes over days to weeks. Okay. So when we compare it with hyperosmolar hyperglycemic state, it's usually diabetes mellitus type 2 patients. They relatively they have insulin resistance. Usually they still have some insulin in the system, but the cells is resisting the insulin to insert the glucose inside the cell. And they also have exacerbation usually related to stress, and the stress in the elderly population usually related to dehydration. So they will be severely dehydrated, and they would also have the glucose to be high, but the pH most of the times would be normal. So, and the ketone should not be elevated as in the diabetic ketoacidosis. So no ketone, and more of severe dehydration, and the also because of the dehydration, the severe dehydration, I would expect the kidneys to have a pre-renal isotemia or acute kidney injury on top of that. Okay. So severe dehydration and hyperosmolarity, elderly patient with altered mental status most of the times. Okay. So go to the history. As we said, they would probably have some nausea, vomiting, abdominal pain, and the abdominal pain usually epigastric or diffuse abdominal pain. And the three polys: polyuria, polydipsia, polyphagia. Weakness sometimes, and some fatigue symptoms, anorexia. Physical examination, you should check. Usually they would breathe, like the cosmal breathing is really characteristic. It's kind of deep, rapid breathing, and like you feel like he's breathing so deep, but it's a little bit higher than the normal respiratory rate. So respiratory rate, you can accept up to 19, 20. If it's more than 20 per minute, then it's actually tachypnea, right? So the patient would probably have tachypnea with a cosmal breathing kind of pattern. Sometimes you can smell the ketone, like the fruit, like it's a special taste and smell. The patient will have some kind of fruity, but not in a good way, the smell of that breath. So that goes with the ketone and the diabetic ketoacidosis. And they probably would have some other finding like tachycardia, alias. So investigation, so you would check the glucose. So glucose check at the beginning. Then you check the urine for the urine and the serum ketone. The urine ketone sometimes is limited use because the beta hydroxybutyrate would show up, but other acetoacetate and the other ketone bodies will not show up in the urine. So don't limit yourself. If you're concerned with DKA, then I would check the urine and the serum, or I would check just the serum ketone. I know here in most of the hospitals, we only have urine ketone in the ER, but just keep it in mind. Sometimes even if the urine ketone is not positive or mild, you are missing a big chunk of the ketone bodies that you are not checking for. So keep that in mind. It might be actually in the blood is actually positive. CBC, so you want to check the white cell count if you're suspecting infection as a stressor for this DKA. And also you need to check the electrolytes. As we know, DKA will affect the potassium, will affect the sodium, will affect the phosphate. So you need to make sure that you check all of that, and especially the potassium, to be honest with you. Glucose and the BUN, creatinine, kidney function, we expect that to be affected with the dehydration. And because of the diabetes, chronic uncontrolled diabetes, one of the causes of renal impairment. So keep that in mind. Cardiac enzymes, as indicated, as I just said, and lipase for pancreatitis. So the management, so as we started with, you first correct the dehydration. So you have a fluid deficit. When you wanted to close that deficit, so you can calculate the fluid deficit and accordingly you can manage inpatient. But in the ER, you don't wait to calculate the deficit. You start with at least 1 liter of normal saline bolus to at least help with the improving the circulation. One thing we really need to keep in mind, if you have a DKA patient who is actually with renal impairment and he's on hemodialysis, so that patient actually is not making urine, is just like having hemodialysis and his kidney is not functioning, be cautious with IV fluids because you might actually make the patient volume overloaded with 1 liter even. So the only exception I would have is the patient with chronic kidney disease or disease on hemodialysis or end-stage renal disease on hemodialysis. I would be cautious with the fluids. And if the patient known to me to have severe heart failure with ejection fraction less than 20%, that patient also, I need to be cautious with IV fluids. I don't have to give much, then I make the patient just like go through a volume overload and I have to intubate him. So just keep that in mind, those 2 cases, okay? And you need to consider starting the insulin, but never start the insulin drip before you check the potassium because the potassium level will help you decide if you need to start the potassium replacement before starting the insulin or you don't have to. So if the potassium is more than 5 millimole, then you can start the insulin drip and keep you check the potassium every 1 to 2 hours. But if actually potassium is between 3.3 to 5, which is probably the case most of the times, then you have to start the potassium replacement before you start the insulin. Because as we know, the insulin will take the glucose and the potassium inside the cell. So it's actually going to make the potassium drop in the bloodstream, and you will have patient have hypokalemia. So replace the potassium, then replace the insulin, and you check the potassium every 2 hours, and you keep eye on the glucose. You do the sliding scale check. So like you check it every 2 hours, even the glucose, but you don't do the dosing of saying, you just do the check. So check the glucose and potassium every 2 hours, and you keep eye on the patient. Some people will do the glucose check every 1 hour. It depends from center to center, but 2 hours is okay. And then after you close the anion gap, as you guys know, the anion gap will be high because it's anion gap metabolic acidosis, the DKA, one of the causes for anion gap metabolic acidosis. So you need to keep eye on the anion gap until you close the anion gap with the correction you're making. Then you decide about letting the patient eating after closing the anion gap. This is inpatient work. In the emergency room, you never wait until that point. Even though sometimes in some hospitals here in Saudi, they have the patient stay in the emergency room forever to be admitted, but this is not the standards of care. This patient should be admitted either to step-down units where you have telemetry and like monitored bed with the nurse assigned, or in the ICU, according to some clinical judgment related standards and some lab investigation numbers that they're using in most of the hospitals. Okay, so you replace the phosphorus too, the phosphate and the sodium accordingly. But usually the potassium is the one really get affected first. So you admit the patient and you start managing in patient. What gonna clear the ketone? Your ketone will never get improved until you start the insulin drip. Because the physiology behind this, if you are using the ketone to generate energy and to keep the patient alive, because the insulin is not inserting the glucose inside the cell, the ketone will not stop until I start giving insulin, and the insulin will take the glucose inside the cell. Then I will block the lipolysis and start using normal glucose to generate energy. Keep that in mind. So the keto, the pH, the ketoacidosis, the ketone part, and the acidosis part will not improve until I start using the insulin to improve the use of the glucose inside the cell. All right. Okay. So then we will move to the thyroid emergencies, eczema and the thyroid storm or thyrotoxicosis, whatever you want to call it. So the thyrotoxicosis, a thyroid storm, the key component to call it thyrotoxicosis is to have altered mental status. To say I have thyrotoxicosis. Thyrotoxicosis is a thyroid storm. I have hyperthermia and altered mental status, plus the other thyroid-related symptoms like tachycardia, palpitation, and the sweating, all the symptoms related to increase in the thyroid hormone, plus the hyperthermia and the altered mental status. Even if I have normal temperature, but I have altered mental status, I still call it thyrotoxicosis. Okay? So it's a clinical decision to call it thyrotoxicosis, and the treatment. Just think about how I should block this storm. So I need first to control the symptoms if it's affecting the heart. So if the patient, usually these patients come with atrial fibrillation or arrhythmia related to this increase in the thyroid hormone. So I need to give beta blocker to control the symptoms. Then after, did you guys notice that we always try to protect the heart first, then we start managing? With hyperkalemia, we give the calcium gluconate, calcium chloride, to protect the heart from the arrhythmias, then we start treating the hyperkalemia. Here the same, we are giving the beta blocker to protect the heart, then we start treating the thyrotoxicosis. So you give that to stop the effect of the thyroid hormone by giving beta blocker and steroids. Corticosteroids also helps with that. Then you start inhibiting the production of the thyroid hormone and the secretion by giving the anti-thyroid medications. Okay. So myxedemic coma, it's the opposite when you have very low thyroid hormone, critically low. And this is also the cornerstone of diagnosing this is actually to have myxedema, like edema, pitting edema, and sometimes actually it's non-pitting. And you have altered status, same thing. So you have a patient present to the emergency room with altered status, confusion, delirium, or whatever, with also myxedema, edema involving the lower extremity. And the patient probably will give you, family will give you history that the patient have history of thyroid problems. And she, let's say, had surgery done before, and he's supposed to start on thyroid therapy, thyroxine therapy, and the patient did not take the medication over the last 10 days or so. This is one of the scenarios. So you check the thyroid level, but that will not stop you from doing the management. So it's a clinical decision. It's not dependent on the thyroid level, the TSH or the T3, T4. No, you're actually considering it the possible diagnosis, and you act accordingly to protect the patient. So you do give the corticosteroids, and you also start replacing the thyroid hormone. Very critical, should be done inpatient most of the times in the ICU. And you would expect to have also electrolyte disturbance related to that. Okay. All right, that's it. Any questions, concerns? عادة أنا أسئلتي تكون غالبا يا الكلام اللي تكلمناه. طبعا السلايدز الأولى كانت فيها بعض الأمور يحتاج تعديل، أتمنى تكونوا عدلتوا كل الأخطاء اللي في السلايدز الأولى، لكن عادة من السلايدز أغلب أسئلتي 90% تكون من السلايدز. ممكن شيء يكون تكلمنا فيه ووضحناه بشكل كبير أثناء المحاضرة نحطه في الاختبار، لكن ما يمكن أجيب لكم شيء ما تكلمنا فيه ووضحناه أو كان يعني ما هو موجود في السلايدز. يعافيكم جميعا.
Thank you so much, Doctor. Appreciate it, and wishing you a smashing day. Take care. Thank you so much. See you later on.